Thank you, Debbie. And my thanks to the National Academy of Sciences, the Institute of Medicine, and the members of this committee for the invitation to address you today. I was told I was going to present on resources, so I wore my banker suit for the presentation today. But as indicated in the opening, I'm going to talk very broadly about the issue of resources. It's going to be a bit of a good news, bad news presentation, and I think it's emblematic of the state of affairs in the healthcare arena these days. I've spent about 20 plus years doing research and field work on the charitable obligations of tax-exempt hospitals, and have seen a pretty steady movement from what many of my colleagues in the hospital arena would call random acts of kindness to more strategic investment by hospitals. But again, inconsistent with the good news, bad news dynamic, while there are a fairly large number of what I would view as outstanding practices out there, many, if not most hospitals, are still pretty early on the learning and action curve. And so our challenge is, how do we bring those hospitals along? How do we bring those health systems along in the context of the reforms and the kinds of transformation that we want to see? So with that, I'm going to roll through these slides fairly quickly. My overview, I'm going to touch a little bit on health reform, the opportunities presented by fairly significant expansion and transparency, talk a little bit about the policy tools that are available and being considered, and then really grapple with this issue of compliance and contrast that with really a focus on transformation. Then I want to touch a little bit on some of the challenges that we are confronting and then summarize some of the priorities moving forward. So IRS has done us an immense favor while I would quibble with and have with a number of the elements of the revised 990 Schedule H and in particular as it relates to what we're talking about, this slow movement on providing hospitals with the opportunity to take financial credit for investments in what we would call community building. But it has nevertheless generated a very large volume of invaluable information. And that information is not just for consideration in terms of federal policy. In fact, I would suggest, and I think there is emerging evidence, that it may become most important at the local and regional level for a broad spectrum of stakeholders to ask the right kinds of questions about what hospitals are doing. But more broadly than community benefit, obviously the article Bitter Pill by Brill has really highlighted some of the dynamics in terms of pricing and the lack of transparency historically in that regard, and there's a lot of movement towards more comparative analysis of reimbursements and shortfalls in community benefit as an outgrowth of that issue. People are really beginning to think, let's look more closely at these dynamics as well. And then in terms of outcomes as it relates to pricing, what are we getting? What are the outcomes for a range of procedures? This is in the clinical care arena. But I want to shift now where my focus has really been, and that is thinking about community benefit in geographic terms. And that pretty quickly takes us to looking at where hospitals are located. We can go back to the 80s, and a lot of researchers pretty well documented and made the case, I think rather effectively, that location often means more than your articles of incorporation. There are a lot of exceptions to that, but if your hospital happens to be located by historical accident or by location decision in a more affluent area with a better payer mix, and if you are in a jurisdiction that more broadly is more affluent, then you tend to be better off in terms of the volume, the number of people coming into your emergency rooms, and the amount of services that you have to provide that may be less than optimally reimbursed. And that obviously is a significant issue as it relates to the social determinants of health. and hospitals are just beginning, and I do mean just beginning to come to terms with the implications of this in geographic terms. So, and then the other dimension of this, as I mentioned the IRS reporting requirements, we're beginning to set up, and we're working on a study to be released within the next month. It's funded by the CDC, that is intended to provide a set of online tools for a broad spectrum of stakeholders at the local and regional level to begin to ask these questions. So, so on this issue, we really need to be asking our institutions how they're defining community. The IRS encourages hospitals to use their geographic service area as the starting point for that. And we know through a variety of sources that there may be inconsistencies in the way that one hospital defines community for community benefit purposes. That is largely around their primary service area and where there may be geographic concentrations of health disparities. Moreover, those geographic concentrations may be relatively proximal to a hospital, but in other legal jurisdictions as well. And it's important to take that into consideration. And one of our experiences in engaging a lot of hospitals is the view that if these concentrations of disparities are not immediately in our backyard, given a focus on the provision of clinical services and given a general insular orientation, that those areas are viewed as outside of their focus and their responsibility. What we are continuing to see, despite extremely limited resources in rural areas, are the roughly 1,300 critical access hospitals out there are all still doing their own assessments. We have a lot of rural local health departments that are still doing their own assessments. It is an immense waste of resources to not come together in this regard. So one of the tools that we developed is a map. It's called the Vulnerable Populations Footprint Map, and it is on at the website www.chna.org. And what I'm showing is just a sample map. And what you see on this map are the H's are locations of hospitals in this metropolitan area. You have a light tan area, which is a set of census tracts where the percentage of the population under the 100% of the federal poverty level is 40% or more. Then there's a darker area where both that threshold is met and there is a population, the high school non-completion rate is 40% or more. We use these two metrics as proxies for where there are concentrations of disparities. Then show county jurisdictions, the hospitals, and then the smaller plus signs are where there are community health centers. The point here is there's another dimension that's about to be added to this. We decided we wanted to be able to show the census tracts that represent the top quintile of income. So what you will see in a very short period of time on this same map are bright green areas that represent those more affluent census tracts. And what you'll see is some hospitals are located much more closely to these more affluent areas and more distal to where these concentrations of poverty are. And the idea is to provide people with the means to ask questions. In the study that we've just completed for the CDC, we looked at 15 sites that were randomly selected, and we chose those 15 sites in part upon the criteria that they had these geographic areas, sub-county areas, with concentrations of poverty that met this threshold. Among those hospitals involved, we basically have four groupings: large metro, small metro, micropolitan, and rural. These are the two sets of the large and small metro. And what you see here is when we went through the community health needs assessments that were available on the sites of these hospitals, there were 44 hospitals that we looked at that we had these assessments available. And we looked at how they define community, and we looked throughout the assessment to see the degree to which they identified where these geographic concentrations of health disparities are. And what you see here is there were basically less than a third of those hospitals in those large and small metro areas identify these areas where there's concentrated poverty and obviously concentrated health disparities as well. About a third identified that there were disparities, but identified them largely in racial and ethnic terms, not that they happen to be located in these areas. Similarly, when we looked at micropolitan and rural areas, there was actually only one of those hospitals that identified disparities in geographic terms in their particular area. So overall, 10 out of 44 hospitals in these areas where there were these geographic concentrations of disparities, less than a quarter identified these areas in their assessment. So we can't say at this juncture whether or not that was inadvertent or there was intent behind it. But it highlights the need to begin to focus these efforts and to be more thoughtful about how the subsequent implementation strategies are designed to address these issues. So back to the IRS reporting requirements. They require hospitals to consider input from community stakeholders in the community health needs assessment, but say nothing about how they're engaged in priority setting and how they determine where those priorities are, or in planning and implementation processes. That doesn't mean those questions can't be asked at the local and regional level, and we're providing tools for people to be able to do that. So what we found often were that priority setting processes were poorly designed and poorly implemented. I have to say, many years of working with public health departments, I can't say we've done that much better in many arenas. It's often we get to the end of the assessment processes and people are exhausted and want to move on. But it happens to be one of the most important areas of consideration if we're thinking about investing scarce resources and looking at ways in which to align those. I won't touch on these others in any more detail, but there are a number of things that we're finding that tells us there's a real opportunity to learn from this early stage in the process. This is not intended to embarrass, and we will release a public report that actually blinds the identification of the institutions involved, but as an effort to help begin to build understanding of the areas for improvement. So that's where we are, and as it relates to the IRS, there are a number of tools, some of which have been out there, some that are newer to the game, that it's important to consider that have been proposed. One that's been around for quite some time is the concept of payment in lieu of taxes. In the Pennsylvania Community Benefit Law, they gave hospitals the opportunity to actually get 3 times the credit if they just write a check rather than invest in community benefit. I'm not a big supporter of pilots in particular because they tend to have money goes to the general fund. It generally does not get allocated in a more targeted way towards health and prevention areas. Determination of needs is basically a variation on certificate of need in Massachusetts, where there's any significant building by hospitals, they are expected to invest some portion of dollars in prevention-related issues. And then what are called community benefit agreements, interestingly, because these came about for the most part in the broader urban development arena when a urban area decides they want to build a stadium, a sports stadium, has to be a community benefit agreement that's part of it that obligates some allocation for low and moderate income people that are often in the immediate vicinities of these stadiums. And they're now beginning to be applied in a number of arenas, in fact, to hospitals. In San Francisco, one of the largest medical centers there, California Pacific Medical Center, sought to build a very large hospital downtown. At the same time, it was planning to close another hospital in the system that it is part of in a lower income part of the town. The supervisors, the city and county officials basically said that this hospital will not be built until we can agree upon a number of things that you will do in exchange for building this new hospital. And then, as we hear from a number of colleagues, I've heard of this most frequently in Boston, where the mayor would come to the large health systems and say, I need help getting this project underway. Will you write a check? Some of the more recent developments in Los Angeles, you can look at what's called the Los Angeles Wellness Trust, and it's a proposed ordinance that basically requires hospitals to put in 1% of their general operating revenues into a prevention trust fund on an annual basis, unless they can be accepted for financial challenges. And then we have, at least in some areas, efforts where there's voluntary pooling of resources. Kaiser and others have in the past contributed to a pooling fund that the Northwest Health Foundation has allocated for prevention purposes. So all of these in essence are hospitals writing a check. I want to emphasize that it basically leaves them out of that game. And really our challenge and our opportunity going forward is how to make sure that they're a part of the process, they're a part of the transformation. So a lot of this work that I've been engaged in and others is how do we in one hand challenge hospitals to do the right thing, on the other hand have them at the table working together to begin to build the population health capacity that they need as a partner to move this agenda forward. So Sarah Rosenbaum and her colleagues at George Washington University put together a set of guidelines that many of you have seen that we've used here for highlighting what we would characterize as the difference between a basic compliance orientation and one that is focusing on transformation. And each one of the headings in the middle are one of 7 guiding principles that that Sarah and Maureen Byrne and her colleagues developed at GWU. So what you'll see on the left are basically what is required by the IRS, and just pick a couple examples where in defining the community, hospitals are required to use their geographic service area. They're charged to identify the underserved populations. But there's nothing that tells them that they can't design programs at that service level. What we are trying to encourage hospitals to do is to make sure that they're identifying where those geographic concentrations of health inequities are within that larger service area and really begin to focus their resources where those needs are greatest. The last 3 elements of these guidelines, you'll see that the IRS is largely silent on some of the most important areas that we're talking about, which is how do we pool and share data, how do we really incorporate continuous improvement and move towards more evidence-based investments. So this and the dialogue with hospitals really has to be, this is not just how you comply with what you're required to do at the federal level, but how we can really work together to help you in a way as we move towards global budgeting that will be essential for your economic survival in the not too distant future. So one of the things that we did in this study was begin to look across the board. For anybody that's been involved in this realm of assessment arena, you'll discover pretty quickly that our communities are assessed to death. And there are a wide array of organizations that are engaged. So on the left, you'll see what are called health impact assessments. These are periodic assessments that may be ordered. Of course, local health departments, tax-exempt hospitals, community health centers, United Way, community action agencies, and in fact, financial institutions, banks, are engaged in what are called performance context, and it really is an assessment of the degree to which they have fulfilled their Community Reinvestment Act obligations, which has, if you look at maps of the ways in which, of where they should be investing, there is an almost 100% overlap. The same census tracts that we look at, that we're trying to encourage investments by hospitals, and these other entities are fully engaged. So this is an attempt to look at where are the potential overlaps in terms of how each of these entities define community, what are their core expectations of each of these kinds of entities. In what ways are they expected to engage community stakeholders? And they all are. What are the accountability mechanisms? Now, I assume these slides will be made available. I don't want to spend a lot of time on them right now. And then what are the opportunities for alignment among these organizations? So just a quick note on this issue of data pooling and data sharing. We just completed a study in California, a statewide assessment of the roles and contributions of community health workers and promotores. And one of the things that we found was almost none of our community health centers who are very much engaged with community health workers could in any way identify ways in which these workers contribute to the triple aim. And the core reason is in part that they lack the analytical capacity. But the other issue is they did not have access to hospital utilization data to be able to get their arms around the total cost of care so they could begin to get at what that return on investment is. And so we've got to address this issue sooner rather than later if we're going to begin to address it. But it represents a very specific area where we need to be thinking about alignment. Same issue as it relates to broader health workforce development. We have each of our hospitals in any particular region that are looking at what their immediate needs are for frontline workforce folks, but there really is almost no funding available for regional approaches and for an infrastructure that will support an approach that optimally leverages the resources of the hospitals and the clinics and the other providers in those particular areas. So this is a real challenge that we have that has to do with the funding streams that are available that really focus on what some might call creating a backbone entity, but it's really an infrastructure for collaboration that will foster the kind of alignment of interventions and the alignment of investments that we need to see. If you don't have it, people are going to fall back on the way that they've done things before. So we've got to really think strategically about that. So it's an interesting dynamic. This is sort of the bad news part of the good news, bad news dimension is at a time where hospitals are really having to grapple with the fact that we are moving towards a population health mind frame, that they're going to have to build population health capacity, that they're completely overwhelmed in most local hospitals with grappling with a number of other issues. Developing their information systems, consolidation, acquisitions. They're trying to look at how to position themselves in the marketplace. They're looking at how they can begin to tighten their belts as they look for things going away from dish funding to other kinds of constraints on reimbursement. And they are still tending to look at community benefit as a compliance issue. So that gets in the way of how they think about focusing their resources, and it gets in the way of them looking at the staff that are responsible for this work as really helping, thinking of community benefit not just as something we have to do, but as the engine for the transformation that needs to occur. Now, I would say I had the pleasure of getting to know a good number of health system leaders, and unless they have their head in the sand, most of them get that this is where we're going. But unfortunately, we're not going fast enough, and they still have to operate in this fee-for-service world. So this is the real challenge. How do we begin to trip this over in a way that people see, okay, we can begin to take these tentative steps in the right direction? The other challenge is the local leaders that report to these system leaders, they don't even know what they don't know. And when you talk to them about population health, in most cases for them that is a panel of asthma patients. Has nothing to do with where those panel of asthma patients live. So it's beginning to make that contextual connection that is really essential to begin to drive this process. But it's a challenge because there's all of this movement and acquisitions and separations that are going on that it is hard to be, for many of these health system leaders to say, you will do X, Y, and Z until sometimes it's too late to do X, Y, and Z. So, but all of this calls for how do we take a problem-solving approach to this? If it's just about saying you will do this or just about writing checks, it doesn't facilitate the movement that we're talking about. The other thing that we're finding, and we're going to hear from some terrific folks here with whom we've had the pleasure to work, as we think about true intersectoral collaboration and working together with financial institutions as they fulfill their Community Reinvestment Act obligations, for example. It may be as much or more of a challenge to look at ways in which to get competing hospitals in an area to actually co-invest in a specific neighborhood or set of neighborhoods. In part because the mindset is still, for the most part, on the coordination of clinical services. So in that sense, even though in the past it's been bad business, it's been the uninsured or underinsured, as these folks begin to get enrolled, there's more and more thought about how do we compete with our colleagues on these issues rather than how do we really bring these pieces together. But the other dimension of that is if you begin to talk to people a little bit about how can we collaborate on beginning to address the social determinants of health, it begins to open that door a bit. So they may still be competing with these clinical cases. Unless we can look at, for example, co-investment in groups of community health workers that are place-based, that are serving multiple kinds of patients. But we've got to find creative ways to break through that tendency to view that we can't collaborate with these other hospitals, because the fundamental reality is, in most cases, they need each other. So back to the bad news. Again, these are the results we saw from the priorities of the 44 hospitals for whom we had the data. Some work on health behaviors, but obviously the predominant area of focus was around clinical care. Very little on the socioeconomic factors, physical environment, and there were a few we just couldn't determine at all. So how do we move forward? I think we have not done a good job, particularly before the advent of the Trust for America's Health. TIFA has really helped move the thinking forward by getting some of these practices out there in a very focused way, as has the work of a group of health systems around the country called the Health Systems Learning Group, now called Stakeholder Health. While there are a relatively limited number of hospitals that are really moving this agenda, we need to better articulate what this looks like and what kind of context it can help move that agenda. And then really use the kinds of tools that are beginning to come out to support local accountability and engagement. The other issue that I have to touch on here is the issue of framing. If we do want to work together with hospitals, we cannot start that conversation with how do we get into your pockets. It's got to be how can we work together to solve this issue. We know what's coming. Let's help you understand what's coming, and let's find a way to leverage the limited resources that you have. Let's help engage and build an ethic of shared ownership in our community, where that really looks at what everybody is contributing to help address these complex issues. If you begin to address this way, you'll have a completely different kind of conversation. And last but not least is a focus on place. I know I'm speaking to the choir here, but this has to be central as we talk about addressing these issues. And anything that we design, if there's no excuse any longer for the kind of fundamental disinvestment we've had in our low-income, predominantly minority communities, we've got to begin to focus our investments in these areas, coming together with the financial institutions, which are charged with, specifically with reversing decades of redlining in these neighborhoods, which created a cascade of disinvestment. We've got to basically turn that issue around. So on this earlier question about have we done enough social spending, really it's the same kind of dynamic in my view that we have when we talk about the availability of primary care docs. It's a maldistribution issue that we have, and we've got to begin to address the drivers underneath this issue if we want people to have, if we want people to success. So in the way that it's been framed most recently by the President in his address the other day, what we're trying to do is address the profound inequities and opportunity in these neighborhoods. It makes a fundamental difference where you were born about the kind of school that you'll go to, the kind of environment that you'll be focused in, the kind of healthy house that you live in, and we have a responsibility to address that. It is a business issue because we will pay for it later on. So a few examples for two health systems that are really beginning to move this agenda. It's a whole new area of investments. Both Dignity Health and CHE Trinity Health have, in essence, community investments division. Here's some examples of some of the kinds of things that they're investing in. These are typically 1% to 2% loans that are being made. Probably one of the most important elements are the pre-development loans that are given to help begin to address the front-end risk that, that basically can prevent from getting banks to step to the table to look at ways in which to invest in these particular communities. But you'll see there's a growing area of investments in a variety of kinds of clearly social determinants of health that can be an important part of bringing these stakeholders together. We're looking at ways in which to get other health systems to emulate these kinds of investment strategies. For both of these systems, that represents about $30 million a year of investments that they're making. They're typically loans between $1 and $2 million. So the general picture that we're looking towards, and this is an example of using the FSG collective impact model, where you've got this core backbone that integrates these sets of activities, the range of different kinds of folks that clearly all have a stake in addressing these issues, and the way that you can interact and address at all of these particular levels. Again, I won't go into any of that in detail in the interest of moving to our panel. And the last slide here is really just touching on how we're beginning to move this agenda from what were originally the random acts of kindness. We began to do some real moving upstream with some of the best practices of hospitals. But now this issue is, how does this become an integrated whole in our hospitals and health systems? And how do they become one player in a balanced portfolio of investments among a broad spectrum of stakeholders? With that, thank you very much. Put that back together.
Thanks, Kevin. Thank you so much. That was a great overview. We're going to break for 15 minutes. I'm going to ask people to come back 10 minutes because we want to get started at 10:15 sharp. Thank you.